Hi, welcome to the latest episode of the Wellbeing Show. I've got a great guest on today who's, by the magic of Zoom, joining us from the west coast of the US, Dr. Clarke, who's doing some extraordinary work around helping people manage long-term and chronic pain, and sort of has pioneered some really interesting sort of psychological approaches and methods to it in the US. So I'm looking forward to hearing about that, as it's a very, very significant issue for many people. Hi, Dave. How are you doing?
Just great. Wonderful to be with you, Noel. I'm looking forward to this.
Yeah. It's great to have you on. I mean, it's a very important topic, the one of chronic pain and how to manage it, because that some of the approaches to managing it can prove more complicated and more problematic than pain originally. So it's a really significant issue, and particularly in the US, in the context of the overprescription of opioids and the sort of chaos that has engendered. I'm really pleased to have you on, to be honest.
Thank you. Yeah, it's the focus that we have is on patients who do not have a injury or organ disease to explain their condition, which could be pain or it could be an illness like irritable bowel or visual disturbances or a whole range of other symptoms. But when the doctors go looking for a disease or injury to explain the symptoms, they can't find anything wrong. And that's where they're often at a loss. And these patients comprise 40% of people who go to visit a physician. So it's a huge number of people, and it's very frustrating on both sides. The physicians are frustrated because they can't find an explanation that fits their training. And of course, the patients are frustrated because they're not getting better.
Yeah,
And some of them have been ill for decades. But
yeah.
the good news is we've got a positive, effective approach for this.
Yeah, and we're going to hear more about that. So tell me, first of all, a little bit about you and your background. You live on the west coast of the US, is that?
Yes, lived in Portland, Oregon, in the Northwest for the last 40 years,
Yeah.
but grew up on the East Coast, but ended up marrying a woman from Southern California, and we compromised on living in the Northwest, and we've just loved it. It's a beautiful part of the United States, and raised our kids here, and just really enjoyed it.
Yeah.
But I went to medical school at the University of Connecticut, and then I did my post-medical school hospital training at Harbor UCLA Medical Center in Los Angeles, which was a fabulous place to learn to be a doctor. I was there for 5 years. And that's where I got my start in this field. I encountered a patient that even after 7 full years of training, I didn't know the first thing about diagnosing or treating.
Yeah.
And I was helped by a psychiatrist on the faculty there to understand how these patients could be successfully treated, and began my practice from there.
Great. So how did you begin to get involved in this field? Because as a physician, you weren't necessarily taught about psychosomatics as such, and which is the sort of area that we're going into, how sort of stress and psychological issues translate into physical symptomology. Which I would guess, if I was to speak to GPs and general practitioners here in the UK, they would say roughly half of their caseload is that, and they're trying to figure out what to do with them, right? So
Exactly right. Yeah, it's almost embarrassing to admit as a doctor that I didn't get training in this when it's 40 or 50% of people that are coming in to see a physician. You would think that, if it's a population that's almost double the size of the people with diabetes, that they would teach you something.
yeah,
But instead, in the eighth year of my training, where I thought I was, getting to be a pretty widely knowledgeable physician at that point, but I encountered a patient, the last thing I expected, a patient that I didn't know the first thing about diagnosing or treating. She had a severe abdominal condition. She'd been referred to us by another university because they couldn't figure out what was wrong with her. And we did a very specialized test on her intestinal organs, which my department chair and I were absolutely certain was going to show what the problem was, because as far as we were concerned, no other explanation was possible. And when that test also turned out to be normal, we were just thoroughly perplexed. And it was left to me to do her exit interview and essentially tell her that she was going to have to live with this. But just to, keep the conversation rolling a bit, I asked her about stress. She didn't have any. She was happily married. She had 2 kids. She worked half-time in a bank, and that was going fine. Then I asked her about stress earlier, thinking, she'd been ill for 2 years, thinking maybe something bad had occurred, a trauma or otherwise, 2 years before. And that was when she started telling me about her father sexually abusing her. And in fact, her father had raped her hundreds of times up to the age of 12. To this day, it's one of the worst stories of childhood sexual abuse that I've heard.
Mm,
And I'd never heard that kind of history before from a patient. I had no training or background in what to do with it. I don't have a psychology credential. I certainly didn't see how it was possible for sexual abuse from decades ago to make somebody ill in their late 30s.
mhm,
But I had vaguely heard about this psychiatrist whose name is Harriet Kaplan, who later became my mentor in this field, that had an interest in these sort of mind to body conditions. So I
sure,
got the patient an appointment with Harriet, and thinking, not much is going to come of that, but maybe it'll help her live with her condition a little better. And then I forgot about her until several months later. I ran into Dr. Kaplan in an elevator, and just to make conversation, I said, whatever happened to that patient that I sent to you? And she said, oh, I haven't seen her in a few weeks now, Dave. The patient is cured.
mm,
She's not needing to take any medication anymore. She's fine. And that just blew my mind, that
mm,
you could alleviate a serious physical condition just by talking to somebody.
mhm.
Never heard that before.
Yeah,
But
I just want
I
to,
started learning from Dr. Kaplan after that.
yeah, I'm going to interject just there because sometimes when we talk about these subjects as clinicians, we forget that there's people listening, and some people may have been triggered by these ideas of incestuous abuse. And I just want to say, as a sort of health thing, if you're feeling uncomfortable in this conversation, if you're listening to this and it's triggering memories, or maybe or you're getting some treatment for it, know that that's okay. That's normal. You're going to get triggered and you may have some uncomfortable symptoms from that. But also be aware that if you're in treatment with any of these conditions, do reach out to your practitioner and talk to them about it. Have a think about whether the rest of this show is for you, and you're welcome to stay, but make sure you have support. And also there's organizations like Rape Crisis, which exist in the UK, and there'll be similar organizations in the US that you can reach out and talk to. So it may be that this is an opportunity for you to seek support for issues that you've lived with. It's certainly not unusual to me in the field of psychology that people carry trauma from their childhood into their adulthood, and that trauma manifests as physical illnesses. Sometimes as a defense, because we can't bear to think about what happened, right? And so it's easier to have stomach problems than it is to recognize that you've been failed by a parent, and awfully failed by a parent.
Yes.
So if you are feeling uncomfortable, that's okay. Monitor your levels of discomfort. Make sure that you have appropriate support, because we're going to be talking about childhood issues, because this is the area that Dave works in and works very successfully in. Sorry to interrupt you, Dave, but I thought it was
No,
important.
no. And also that there's hope, that even a patient who had been through such a horror was able to have a successful outcome. Not
Yes.
everybody's going to have a successful outcome in a matter of months the way she did, but that there is a pathway toward healing, and that provides a lot of hope for people who have suffered similar issues.
Yeah, and I think it's also the case, it's very often the case that people who've experienced childhood trauma may not remember it, depending on how or when it happened, because memory issues are an issue for trauma, but also they may have pushed it to one side because they were told it didn't happen, and it then somatizes more. And we're going to talk a little bit more about those processes. So you have this case with the psychiatrist, and it transforms or begins that transformation of your understanding of this whole cohort of patients that you've got with these unexplained illnesses that keep coming back, and no matter what you try medically, it doesn't seem to clear it up. But that's a familiar story to me. You say you started to train with Dr. Kaplan. Can you tell me a bit more about that, what that was?
Yeah, well, for the next year and a half, the last year and a half of my formal training, before I left Los Angeles and came to Oregon to start in practice, we had her sit in with us in the outpatient
Oh,
gastroenterology clinic, and we would always find patients who had these issues, and she would help us to understand them. She gave me a framework for how to think about them, what kinds of stresses I should be looking for. Sometimes it was adversity in childhood, but it could be stress in your life at the moment.
okay.
It could be depression, anxiety, or post-traumatic stress that wasn't manifesting in an obvious mental health sort of way, but was instead manifesting in a physical way. And that turns out to be very common, that, especially people with depression may feel like I'm not that depressed, but yet they have lots of other symptoms that are correlated with depression, and they have the physical manifestation that brings them to the doctor. So I learned to sort of systematically go through each of these different areas of human stress until I found something that connected with the rise and fall of the patient's symptoms, or happened, right before the symptoms began, that was a trigger for those conditions.
Right.
And then, usually when you bring that out into the open, once you've found the stress, it's almost always something that can be treated successfully. Not everybody's going to get better rapidly, but even people that are going to need years of psychotherapy to achieve a good outcome, at least they know that they're on a pathway toward healing. And
Right.
that gives them tremendous hope. It removes the doubt about what's going on in their bodies. They don't have to think that they're going crazy because the doctors can't find anything wrong. They now have an explanation that makes sense, a pathway toward getting better. It's a night and day difference for them.
So can you explain to people who are listening the link between stress and illness? Why does these unresolved stresses manifest in sort of physical illnesses? People maybe understand that they have depression from stress or anxiety from stress, but maybe don't understand the link with physical health so much.
Well, our brains are connected to our bodies, as one of my mental health colleague friends said. Anybody who has a neck, their brain is connected to their body. So that's, pretty much everybody.
Absolutely right.
Some of us have more necks than others, but
Yes, right.
another easy way to think about it is that, if you've ever blushed with embarrassment, that's a brain to body reaction. Your emotions are triggering a physical reaction in your face. Or if you're in a tense situation and you feel a knot in your abdomen, or you feel that, butterflies in the stomach sensation, that is another phrase. That is, again, your brain is having a reaction to something going on in the world, and you're feeling it physically. Or, your heart is pounding because you're terrified or you're excited. All of these are physical reactions in relation to emotions, or to stresses or traumas. And this form of illness is just a more significant and long-lasting form of that kind of brain to body reaction. And
Mhm.
what's surprising to people, and was definitely surprising to me, is just how severe it can get.
Yes.
I One of my patients was ill with this for 79 years.
Wow.
Another patient of mine had 27 distinct symptoms in his body.
Yeah.
Another patient was a 17-year-old whom I was asked to see on his 70th day in the hospital, and he was getting morphine around the clock for unexplained abdominal pain. He had seen 6 other gastrointestinal specialists before me in the preceding 18 months. And the morphine doses he was getting 10 milligrams an hour. And 10 milligrams is more than enough to alleviate the pain of a fractured leg. And he
Right.
was getting this every hour for this unexplained pain. So just, again, an example of just how real and severe this can be.
Yeah.
These are not imaginary. These are not, quote unquote, in your head. These are real.
Yeah. Yeah. No, well, I find the notion of it's in your head quite a strange concept anyway, because as though your head isn't connected, as you said, it's not part of your body somehow. But it's of course there's also, and correct me if I'm wrong, but there's a very direct link in many ways between brain and gut, for example, because the gut has a lot of neurological material in it. Is that correct?
Yeah, it has about as many nerves as the spinal cord in one example, or 5 or 10% as many as in your brain. The gut nerve network has been called a second brain, and the signals go back and forth. They can go in either direction, and in fact, a lot of the probably a majority of the signals are going from the gut to the brain, and your brain has to process that.
Yeah.
But it turns out that if you have suffered stress, adverse childhood experiences, for example, the circuits that are processing those signals are different than they are in healthy people that don't have these conditions like irritable bowel. So when the signals are coming up from your body into your brain is doing something different with it. And that's been seen by functional magnetic resonance imaging studies in people who had childhood adversity, people with what's called somatization disorder, irritable bowel, fibromyalgia, even as experiments where
Yes, the
they make people feel
fibromyalgia is really
excluded.
interesting. It's really interesting fibrom because there's some recent research, and I'm trying to remember exactly what he was saying, but there's a link between fibromyalgia and ish. Sorry, I don't know why my computer does this. It sees my stop.
It appreciates your
So
comment.
it's sort of like I have to keep my hands down in case it
You're
does.
getting some validation there, Noel.
I am, or you're getting the validation. You can have it. We can both share it, right?
Okay, works for me.
And there's more and more sort of evidence about how some of these long-term conditions are affected by certainly by adverse childhood experiences. Now, ACEs, adverse childhood experiences, are a very evidence-based approach to measuring somebody's vulnerability to later life problems. Do you use them sort of routinely now when you've got unexplained pain? Is that part of your methodology?
ACEs are extremely important. They are present in a majority of the patients that I work with. And I actually spent a week with Dr. Felitti, who was one of the inventors of the first ACE study. He was
Wow.
one of the authors of the first
Yeah,
ACE study.
you seem some great people. I'm so like in oh wow, I'm so envious. Wonderful.
However, even Dr. Felitti doesn't use the ACE study as a routine screening tool,
Yeah,
and there are two reasons for that. It's too long and it's too short. It's
yeah,
too long because it's 10 questions is the standard questionnaire, and that's a lot for a busy primary care practice. But it's also too short because there are a lot of ACEs that can have a long-term impact on people that are not asked about in the standard 10-item ACE questionnaire.
yeah.
So what I did was I boiled the whole thing down to one question. And the
Okay.
one question is, if you learned that a child you care about was growing up exactly as you did, how
Oh,
would that make you feel?
brilliant. That's absolute genius, Dave.
And I give
Yes.
people in my written
Yeah.
questionnaires 4 different possible answers. They'd be happy if they learned that a kid was growing up the way they did. They'd be neutral about it. They'd be sad or angry, or they'd be very sad or very angry.
And then that gives you the indications. There are the flags for
And
you.
those are the flags, and it's also the starting point for a conversation.
Yeah.
But just out of curiosity, I took that one question with the 4 answers and correlated it with the 10-item standard ACE questionnaire. And it was a linear correlation. The more sad or angry you would be about a kid growing up the way you did, the higher your ACE score was. And it went from the people who said they'd be happy if a kid grew up the way they did, they had an ACE score of 1.
Yeah.
Or slightly over 1. The people who would be very sad or very angry, they had an average ACE score of over 7 out of 10. Just
Yeah.
extraordinary, and it went up linearly. So I just used that one question, and it for me it gathers all the information that I need to dig into their background in the next step.
Yeah. I mean, you won't capture everybody, but you'll capture a lot of people
A
that
lot,
a lot more than we're capturing now. I'm telling you.
yeah,
That's
yeah,
sort of like,
and it's the another important thing to realize is that stress in childhood, adversity in childhood that's capable of having a long-term impact doesn't have to be the obvious kind. It doesn't have to be, sexual abuse, like I mentioned earlier, or, violence in the home, or substance abuse by the parents, or divorce, or, any of a number of, obvious traumas that can happen in a family. It can be much more subtle than that. It can be pressure to perform.
Yeah.
It can be a lack of support. One of my patients grew up in an extremely religious household where the standard of behavior for the children was Jesus Christ. And
Well, that would be unreachable.
if the children failed to reach that level,
That's right.
they were shamed.
Oh dear. Yes, that would be.
No surprise that that individual was struggling as an adult.
And so, what are the types of symptoms that you were seeing in patients? I guess now when you see them, you just go, "Hang on a minute, I need to ask that question." So, what sort of things were you seeing?
Well, as a gastroenterologist, early in my career, I was seeing all kinds of gastrointestinal problems, from burning chest pain resembling acid reflux, but not acid reflux, just the burning chest pain, nausea, vomiting, indigestion, diarrhea, constipation, rectal spasms, bloating, all of those things. But as time went on, and my colleagues in practice and in the wider community found out about what I was doing, they started sending me patients who didn't have gastrointestinal symptoms. They were just medical mysteries, and they might have, untreatable migraines,
Yes.
ringing in the ears, or also called tinnitus, dizziness, visual disturbances, pseudo seizures, stiffness and pain in the jaw, swallowing problems, difficulty breathing, pain in the spine, low back pain is very, very common. Bladder spasms, pelvic pain, joint pain, numbness and tingling in the extremities, something called functional neurologic disorder, recently long COVID, chronic fatigue, fibromyalgia. And the only common denominator is that these patients tend to have more than one symptom at a time. They don't always, but many of them have more than one. My personal record was the patient I mentioned earlier, 27 different symptoms. But the more symptoms people have, the more those symptoms move around in the body, the more likely they are to have the brain as their origin.
I mean, it's really interesting for me listening to you, because from the psychological side, I often see people who come in with, they've got multiple diagnoses. And that's usually a red flag for me. Oh, what have we got here? And people collect these diagnoses through their life because somebody hasn't sat down and gone, right, let's try and figure out what's actually happening here. And usually, but I have a bias because I work on the psychological side of things. It's usually, in my experience, stress responses that have gone into traumatic responses, and sort of I see stress and trauma on a continuum, to be honest. I don't really sort of see. What people may have been surprised about is your use of the word stress in relationship to, say, depression, for example. Periods of depression producing stress responses. Can you say more about that and sort of what your clinical experience is of that? Because I don't think I necessarily say the connection.
Yeah, with depression, anxiety, and post-traumatic stress, it's not unusual for the patient's principal manifestation of those conditions to be a physical symptom. And so they come to the healthcare system, not to a mental health professional, but to a medical clinician with the physical symptom as their main issue. And, if they're lucky, the physician may ask them, do you feel depressed? But so many of these patients in my practice say no. They don't feel depressed or anxious. And the probable reason for that is that they've been depressed and anxious for so long that it just feels normal to them.
Yeah, absolutely.
So I've learned to ask, much more detailed questions. How is your general energy level? Have you lost interest in activities you used to enjoy? Is your sleeping disrupted? Are you crying for no obvious reason? Have you had thoughts of harming yourself? All of those kinds of questions. Is your appetite off? And typically a patient will be saying yes, 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 yes to all of those, even while they're saying, no, I don't feel depressed. I'm stressed, I'm exasperated, I'm frustrated, I'm desperate to have you fix this terrible symptom that I'm coming into you for, but no, I'm not depressed. But when you treat them for depression, they get better.
Yeah.
And it's so often missed, the investigation for these mental health conditions in a medical office is far too often superficial, and
Do you think is
it's
that
missed.
because general doctors, medical doctors just feel out of place, or they just don't think about it? I mean, most GPs I know will probably tell me, certainly in the UK context, that they have a whole cohort of patients that that they think there are mental health problems, but they don't feel equipped to go there with it because they're sort of biological sort of medics as opposed to psychological. Again, that division between biology and psychology, it's such a fake division. It really is. But I mean, you're a bit of a pioneer here, but I guess other medics are turning to you and asking you about it because they're similarly swamped with a lot of people that they find it impossible to treat.
Yes, we trained, just as an example, a small group of family doctors in a medium-sized city on the East Coast, and they just their practices were transformed once they started asking a few basic questions about their patients who had no biological cause for their illness. And they were, these are patients who don't look like they're particularly stressed out, but when you start asking them questions about ACEs, or about what's going on in their life at the moment, and all of these things come tumbling out that can be successfully dealt with. And all of a sudden, this group of 40% of their practice that was frustrating them, now they get a very rewarding outcome out of that. And they just loved it. And they have since, in the last couple of years, trained, they tell me, 70 other doctors in their community how to do the same thing. One of them took me aside at a conference
That's
and said,
literally helping
and
thousands and thousands of people.
yes, but I have to, the last bit of this story is one of the family doctors took me aside at a conference and said, these ideas have put the joy back into my practice.
Really? Wow. Wow. Yeah, because it does grind you down when you can't help people. If you're a healer and you can't help people, it's frustrating, it's overwhelming, compassion fatigue, etc., etc. So absolutely, I would understand that. But also my sense is that medical doctors are a little bit afraid of dealing with the psychological side of things. They feel ill-equipped. Is that your experience as well? That they're a bit.
Yes, they are most afraid that if they even bring this up, that the patient is going to accuse them of blaming it all on imagination in their heads, and is going to want to throw the doctor out of the room. So there is a bit of skill in how to present this to a patient, to say that, this is a common phenomenon. The brain is very powerful. The symptoms are absolutely real. We just need to investigate the source of this, find the underlying stress, just in the same way we would do an ultrasound or a CAT scan or an endoscopy to find an underlying disease or structural damage. And if you present it in that way, it's much more accepted, especially if you do it right at the beginning. Somebody comes in, you're not quite sure what's causing their symptom, so you make the list. If it's a upper abdominal pain, you say, well, it could be an ulcer, it could be a gallstone, it could be your pancreas, it could be stress. And you
Yeah.
just list all of those, and we're going to investigate them all because we don't want to miss anything.
Yeah, yeah.
Patients are very accepting of that.
It's wonderful to listen to because I often say when I'm talking to people on the psychological side of things, you can't forget the biological. So if somebody presents with depression and anxiety, for example, it's really important to have the thyroid checked out to make sure that that isn't the reason. Because if you diagnose anxiety and it's a thyroid problem, the people won't respond to the psychological approaches to anxiety management, and they become more chronic, more disabled. They lose hope. They think there's something permanently broken with them. And I guess this is what's happening with this cohort of patients for whom they need more psychological approaches, or more psychosocial, I would guess, rather than just psychological.
Yeah, and if I don't find anything biologically wrong, and I use the psychosocial approach to these symptoms, and the patient fails to improve, then I'm thinking again about, did I miss something
Yeah.
biological? Do I need to go back and repeat a test? And every once in a while, maybe a dozen patients over my career, something will have appeared that wasn't there before. We'll have done the right test for it. It just wasn't there on that test.
Yes.
Patient doesn't get better with the psychosocial approach. So I go back and look again.
And do you deliver the psychosocial approach, or do you bring in other people to sort of help you in terms of what you do? Because a
Yeah,
lot of it, I think, is pretty straightforward stuff, to be honest.
Yeah, it is. And there are a lot of resources out there now that patients can take advantage of. There are self-help books, there are apps, there are videos that people can learn this from. And for a large number of patients, those are enough. For a smaller fraction, they need individual psychotherapy. And
Right.
what I would try to do is, get people to an understanding of what was going on, and then they could take that to a mental health professional and work with that.
Right.
The mental health professionals all too often are not familiar with the kinds of psychological issues that can make people physically ill as opposed
Yeah.
to
Yeah.
having a mental health issue.
Yeah.
So if I can help the patient to understand those issues, bring them into conscious awareness, then they've got something constructive to talk to the mental health professional about.
It's interesting because right at the beginning of all this mental health stuff, Freud used to talk about conversion systems. And
Yes.
he's not in fashion anymore, and he shouldn't be because there's a lot of nonsense involved in it. But this idea of conversion system symptoms was, very powerful, I think, and is very current in terms of understanding that link that if we don't support people, if we don't help people, it'll emerge in one way or another. It's that game of whack-a-mole, isn't it, that you described? That if we don't get it right, it's going to appear somewhere else. So we need to do these very holistic approaches. I mean, I'm guessing that there's a lot of people listening to this just thinking, wow, finally somebody's saying what I know is true, because the patient often does know, don't they? They
Yes.
because they've been living with it and they're like, I'm fed up with this. I'm fed up with this. I'm fed up with this not working. I need something to work. Can you tell me about the sort of general? Because I'd like to encourage people to think about what is the general sort of psychosocial approaches that they can take, the stuff that doesn't necessarily need a highly qualified psychologist. So the types of lifestyle changes, if you like, that you might advise people to make to help them manage their stress better.
Yeah, that's well, I could talk for the next 30 minutes on that subject alone. I will
Talk for
not
the
do
next
that.
20
I promise. I
years. No,
promise.
I would give you 20 years to talk about it because I think it's so important that we get this information out to people.
Yeah, let me try to summarize that. The most important, the easy ones are the ones where there's a stress going on in the person's life right at the moment. Another one is that we didn't talk about is anxiety. Typically in those patients, the physical symptom, whatever it is, will be more severe or more frequent when the patient is away from a safe environment.
Yeah.
And I'll look for that. Well, a classic example was a patient whose home was safe for her. She only got her symptom when she was away from home. So clearly the brain was involved. She had 100 episodes of her symptom. Not a single one took place at home, where she spent roughly 50% of her
Wow.
time. So clearly the brain was involved in that, because her belly has no idea whether it's at home or away. So that was a typical clue for an anxiety disorder. But the most involved form of treatment is in the long-term impact of adverse childhood experiences, and that they fall into three major categories, all of which are treatable. One is the personality traits that can grow out of it, and even people that don't think they had a very severe childhood, if they recognize that they have these personality traits, they can go back and think about where those personality traits might have come from, what they might have learned about themselves as kids that wasn't true. The typical ones that we see are low self-esteem, lack of self-care skills, poor assertiveness, perfectionism, a detrimental level of devotion to the needs of others, a tendency to have close personal relationships with people that are unbalanced, where the partner takes advantage of them in some way. All of those things are ways that children have grown out of children trying to survive adversity when they were young.
Yeah.
And they can be, those links to the past can be identified, and that facilitates people making changes. One of the big ones is simply self-care skills, being
Okay.
able to set aside regular time for your own joy. And many of my patients, when you ask them, what do you do for fun? And they're like, well, not so much. And they oftentimes, you find out they grew up in an environment where they had to pay attention to everything else in the environment but themselves, and they just didn't learn how to play. And so as adults, they don't they're on a treadmill they never get off, let's put it that way.
Mm.
They're just constantly working on behalf of others. All right, two other major categories of long-term impact of ACEs. One is triggers, which are people, situations, or events that are stressful for people because they are linked to the past. And my patients often don't recognize that these people or situations or events are triggering for them. The most common is a parent who mistreated the child who is still in the patient's life as an adult. One of my favorite stories around that was a woman who was verbally and emotionally abused by her mother starting at the age of 3 or 4. And this was still going on when the patient was age 50 and mom was in her 70s. And it turned out all of her attacks of illness, which had baffled a famous university for 15 years, all of her attacks of illness were linked to encounters with this mother that had a terrible triggering effect on her body. And then the third major category are repressed emotions,
Yeah.
anger, fear, shame, grief, guilt that the patient is not consciously aware of, and consequently, they are manifesting via the body. And if we can help people recognize that, and that question about, imagine a child you care about growing up in the same home that you did, that often helps people a lot to connect with those buried emotions, bring them into conscious awareness where they can be talked about or written about. And the more you put them into words, the less they need to go into your body and cause trouble.
And what would you say to people? Because sometimes people have this sort of can of worms fear, don't they? The idea that you can open a can of worms and you won't be able to cope, and that'll be it, and somebody might get worse, and it might be a risk. What's your sort of understanding of that? What might you say to people around that?
Yeah, I mean, it definitely can happen. It has happened in a small number of my patients. Most of the time, people are delighted that a healthcare professional, medical or mental health, is willing to talk about these issues from the past with them and help them to understand it.
Yeah.
Yes, every once in a while, somebody will just get overwhelmed by the memories or the emotions. And I'm reassuring to people about that. It typically doesn't last for more than a period of a few days. And I'm reassuring that this would not be happening unless your brain was ready for it. And the symptoms in their bodies were a sign that those thoughts and emotions were just desperately trying to get out.
Mhm.
And that they wouldn't be coming through your brain and into your conscious awareness unless your brain had been doing oftentimes years of trying to heal itself. And now it's finally reached the point where it's ready to have this flood come out.
Yeah.
And it typically doesn't last for more than a short time.
And the healthcare professional who might have the similar types of fears, because I think it's more the healthcare professional.
Yeah, well, what the healthcare professionals fear,
I can go.
if they get into this area, the doctors are thinking, okay, I'm going to ask a question about stress of my patient,
Yeah.
and they're going to spend the next 2 hours telling me their life story. So this is something I teach my medical clinician colleagues, which is, when you've got a 15 or 20-minute appointment, you want to honor the patient's willingness to disclose this information. Say, thank you very much for sharing this. It's very important. We don't have the time that it deserves to go through this today. So what I want you to do is to write all these things down in a list,
Great idea.
all the stresses in your life,
Great idea.
past and present.
Yeah.
Bring the list back with you when you come for your return visit. We'll go over it at that time. Patients, they start writing, and oftentimes the more they write, the more they write. They can't stop. They start writing down all these stresses that they were not necessarily fully consciously aware of. It's therapeutic to get this all out on a page. It starts them thinking about solutions for some of these things. Not unusual for the patient to come back with their list, and they're already getting better.
It's interesting because I think way back in the mists of time, family doctors would have had this knowledge about their patients, wouldn't they? Because, you know, communities were small enough that you would have seen somebody born, grow up, you would have known about what was going on. And it's sort of, in a sense, bringing it back to what that family doctor role was anyway, which was the confidant of the community, the sort of holder of that knowledge. And then what types of interventions might you suggest for people around stress management that are subclinical interventions from, say, psychologists? What sort of things might you advise people to do to manage their stress better?
Well, if they're having a lot of anxiety issues around this, certainly breathing exercises, mindfulness meditation,
Mhm.
those are good adjunctive things to do. Setting aside regular time for your own joy that I mentioned before,
Yeah,
um, going out and doing some trial and error to find activities that you just, have no purpose but your own enjoyment.
yeah,
That is an essential human skill that many of my patients never learned as kids. So
yeah,
that's very important. Getting good sleep is
yeah,
important.
yeah.
Ideally, eating a healthy diet as well. But all of these things are more supportive. The key is to really find out what those causative stresses are
Yeah.
and focus on them. The other areas, they're important, they're supportive, but they're not the core of how you get better.
And the types of treatments for the core would be principally psychological talking therapies, somatic
Or
like therapies.
yeah, a lot of what we call pain relief psychology. This is different than cognitive behavioral therapy,
Okay.
which has been shown not to work very well for patients with this issue. Um, there are three major but closely related types of pain relief psychology, and they share characteristics of shifting people's attention from the brain. I'm sorry, from the body to the brain, and then thinking about, all right, what are the stresses that are going on that can impact the brain, and then particularly with the long-term impact of ACEs, working on those. Starting to change the personality traits that are toxic or stressful for you,
Mhm.
putting unrecognized emotions into words. Common technique for me was for patients to write a letter to the parent or parents who mistreated them, not to mail it, just to write it, to put all their thoughts and feelings, good and bad, because often the feelings about the parent are decidedly mixed. But to make sure you get um, all of them out there on a piece of paper or on a computer screen,
Mm.
so that they don't have to be expressed by your body. And then the triggers, if you've got triggers going on in your life, to learn how to set some boundaries. And that's tied in with self-esteem. Many of my patients have been made to feel like second-rate human beings or worse when they were growing up. And I want my patients to look back at their childhood experience as if they'd been born in the middle of a dangerous jungle.
Mm.
So through no fault of their own, they found themselves in this terrible place, but they deserve tremendous credit for having survived that, for having made their way out of it. And
Yeah.
if they can think of it, that early experience in those terms, then they're flipping their self-image from negative to positive, and that has ripple effects throughout their lives.
Yeah, absolutely. That type of reframing. I'm not the victim. I'm a survivor. Uh,
Yes.
and there are multiple studies that show people can have exactly the same life experiences, but their attitude to that experience can mediate it significantly. So
And there's even a magnetic resonance imaging study of the brain that shows that those self affirmations, these techniques for um, honoring your own heroic perseverance that you
yeah,
needed to survive, can physically change the circuits in your brain.
yeah, absolutely. And also there's lots of evidence now, research evidence that shows that things like mindfulness have a direct physiological impact on things like the telomeres at the end of your DNA strands, and you reduce the risk of sort of multiple illnesses that way. So
It's another form of self-care.
yeah, there's a sort of mountains of evidence. And I mean, you've also covered sort of generally, but I'd like to sort of nail it down. There's a thing called I'm sure you know called lifestyle medicine, which is an evidence-based approach to more generalistic health and well-being, which involves stress management, sleep, exercise we haven't covered so much, but certainly diet. And diet, healthy diet being, an 80-20 split of vegetable material to meat to animal material. And just in the UK, we talk about having a varied diet. So it's not monochrome. If you want to know if something's healthy, if it's very colorful, it's likely to be healthy, unless it's sort of additives, but fresh, healthy fruits and fibers, etc. The sleep hygiene thing is really interesting. I think people may be surprised, but you can learn how to sleep better. It's not a life sentence having bad sleep, is it?
That's right. That's right. Yeah, not looking at screens, having a comfortable temperature, making sure the room is really dark, all of those things that you can, Google it on the internet, sleep hygiene, and you'll find all kinds of recommendations, and you can compare your own habits against that and perhaps make some changes.
And what about exercise in terms of the sort of work that you're doing with your patients? Is that something that's valuable to you, do you think?
Yeah, I mean, even something as simple as walking, especially if you're able to walk in a natural environment, there
Yeah.
are good studies that show the benefits of that for mental health as well as physical health.
Yeah, the biophilic effect is, very, very powerful. In fact, it's really interesting. In the UK, there was work done on building parks, green spaces within cities, and around the edges of those green spaces, violent crime would drop by 20% just because the park was there. Isn't that
Very, very interesting. Yeah,
I mean,
I will.
that's
I, I will
real.
add that, all of the lifestyle medicine changes, which I fully support. I mean, I live them myself. But if you are not addressing the ACEs impacts, then those are sort of still in there, and all the lifestyle medicine choices are essentially going to be swimming against that tide. So
Right.
it's very important to um, look into the long-term impact of ACEs and work on that as well,
Yeah.
because everything else will be more effective.
I totally agree. I totally agree. You're pushing at an open door here, David.
That's good.
That's what there's no resistance. Just come on in. But it's really, I mean, it's amazing. I remember when I first started, way back when dinosaurs were still roaming the earth.
Yes, we had the mammoths when I was growing
That's
up.
right. I was a little baby pterodactyl. Now I'm a very crotchety old pterodactyl. But my first real world placement was in a psych ward, acute admission psych ward. And back in those days, you had psychiatrists and you had psychologists. One was biological, one was psychological, and they never met. Except the rest of us were like, hang on, it's not like that, folks. Most of us were in the middle somewhere. And it seems like that's appearing more and more and more now, that we're getting to that place where we're beginning to understand the complexities of this as we listen to our patients and actually start learning from them. This is
Yeah.
how these things manifest. And
The best outcomes are achieved when the medical clinicians and the mental health professionals collaborate with each other.
yeah, yeah, absolutely, absolutely, without a doubt. And we have to do that more and more. We have to sort of cross-fertilize, not become experts in each other's field, but generally be communicating more effectively with each other. I think, there's a sort of an inappropriate split between the two. And when we work cross borders and across specialities, I think we get much better outcomes for people.
Yeah, the practice where I trained the doctors who found such joy in this work, they have access to a psychologist right there in their clinic. So if they're evaluating a patient like this, they can ask a few questions about stress.
Wonderful.
The red flags pop up, and they'll say, "I've got this stress expert over here. We're going to bring her in and talk to you for a bit right here as part of your primary care office visit." Goes over very well.
And I guess one of the primary messages to get across is if you suspect, as a person listening to this, that ACEs are involved in some of the chronic long-term issues that you've had, go armed with that knowledge to your practitioner and ask about it. Use this information to sort of begin to request additional services that can help you work through these. If people want to know more about your work, Dave, how would they get hold of you?
You know, the best is the website of my nonprofit, endchronicpain.org.
Okay.
And we've got lots of resources there. We have a 12-item self-assessment quiz that people can take that takes less than 3 minutes. And the more of those 12 questions to which you answer yes, the more likely it is that the physical symptoms are connected to what we've been talking about.
Yeah. Okay. And we'll make sure when this show goes out, because it's pre-recorded, we'll make sure that we put a proper link to it underneath the show so that people can get hold of it. Are you doing training and talks and things like that? Can you be
All
booked?
the time. Yeah, there was 1 week last October. I gave 13 hours of presentations in 4 different cities in the United States in just the 1 week. So yeah, it's becoming very, very popular. And we've got video courses on that website. We have
Right.
recommendations for books on there. We've got a written course for people that choose to support us as members. So lots and lots of different resources that I dearly wish I'd had available to me back in the 1980s when I started.
Yeah, brilliant. Fantastic. What a fantastic, it's wonderful to meet you. I'm really, really excited by your work.
Thank you.
Really, really touched, and it's fantastic work. Folks, reach out and have a look at Dave's website. We'll put the link. You just stay there for now. I'm just going to end the show and say how excited I am to have had Dave on the show.
Thank you so much, Noel.
Really beautiful stuff. Fantastic work. Folks, I'll see you all at the next show. I hope you found this useful. If you've got follow-up questions, do just WhatsApp me 07506 319 745 and I'll pop them over to Dave, or you can get on his website. I'm sure there's a contact form on the website as well if you've got follow-up questions. But this is fantastic work. I'm really excited. You stay there. Bye-bye for now, folks, and I'll see you at the next show.